I'm delighted. I'm Helen Burston, CEO of the Council of Medical Specialty Societies and a member of the Planning Committee. Really delighted to transition us to the next session. As you heard in our first session, we really had just extraordinary information from our speakers around really what are those pain points, what's the evidence for those pain points, what are the opportunities in tech. Interestingly, so many of the questions in the chat are about implementation. So I think we planned this correctly, because as you'll hear, the next session is really all about hearing from the implementers, those who have data on the ground around what works, what has been implemented, and really how do we decrease the burden among our clinicians, and how do we spotlight those technologies that can really make a difference. So with that, we're going to go ahead and get started. Actually, I think Dr. O'Mahony's system was already mentioned in the last session. So Steve O'Mahony is the Senior Vice President and the Chief Health Information Officer at RWJ-Barnabas Health. And he will highlight some of the technologies they're using, I suspect, including the one we just heard about from Lisa. So I'm going to turn it over to you, Steve.
Hi, good morning, everybody. Thank you so much. And I first of all want to thank the Academy that really recognizing clinician burnout, we all, as a priority, is really just, we're all grateful for that. And also for the speakers before really setting the stage of what the problem at hand. So what I would like to do is really the proof of life. So can we actually do, so it's not just recognizing it as a problem, but can we do something about it, right? So really the theme here is using technology, as we said, as a solution rather than the source. So I think first of all, I have a slide here so people can absorb what it is I'm talking about. I am going to be focusing on Wellsheet. This was a partnership, as said before. This was a true collaboration. Myself, I'm a computer engineer and a physician, but really it's a partnership between the health system and disruptive technology, right? So how do we work together? And so the guiding principle here is that we're not looking to get rid of the EHR. I think we all know it's the number one problem, but at the end of the day, as care is becoming more complex and data is more complex, we need the EHR to do what it does best. It is a source of highly reliable care and decision support. But instead of getting rid of it, we need to make it smarter and easier. For us. And so furthermore, what I will show is that there as the barriers to innovation existed before, myself and I think a lot of us out there, it wasn't that we weren't trying to innovate, but just in the recent past, any innovation we did, the EHR is just such a giant ship that had to be moved. The complexity of making one change and the complexity on how the rest of the EHR worked, it's just a slow process. Not only was it slow, that the minute you put it in and you took an upgrade, it would break, right? So we all understand that because of that non-standardization and the hornet's nest of interfaces as a hornet's nest was just not worth doing. So really what has come is what I want to show is the meaningful use, and promoting interoperability. That new interoperability standard, FHIR API, has really just allowed us to do what I'm going to show here. And this common language of just being able to say, hey, I need to get the surgeon know what the blood count is and not worrying about the thousands of different ways that could be stored in the EHR. One common language has allowed this to happen. So what is Wellsheet? So Wellsheet, this innovative technology company that we partnered with at RWJ Rutgers Barnabas Health, is that what we were able to do is, first of all, it knows who I am and who the patient is, and is using predictive analytics and the API to mine the EMR to do that work. It's a complementary man and machine here. It knows all that, pulls from the dozens and dozens of screens, so I can make sense of the information. So that's number one. But also, this is helping me make better, more efficient decisions, and eventually making me happier. And I'll just point out one thing on here. When you see on the top left corner, so this, first of all, the user doesn't even know. So this can be Epic or Cerner. I'm showing more of a Cerner view, but it's the same. It doesn't matter what EHR you had. It is there, and you don't even notice. You don't even know you're in Wellsheet here. It's right on top of the EMR. It's on the mobile phone, on an iPad, and in the desktop. So you don't have to even worry about that. But not only is it helping me make intelligence of all the scanned documents and 15 other parts of the chart. On the left-hand side, the TAVR, I could be right now, and I'm very happy that I've taken care of this pneumonia patient, but it's reminding me, hey, Steve, what Wellsheet has done is mine the EHR, use natural language processing to take the indices off an echo, knows it already fills in all the parameters of the patient information, and lets me know that not only, I'm focusing on the pneumonia, but all I have to do is click a button, and that's going to put them in a queue for a potentially life-saving transaortic valve replacement. And also, it puts them in line for that on a population health perspective. So the other thing that it's doing right below, it's also, I timed this out. It's not that I can't calculate their coronary vascular disease, but it's about 18 clicks if you wanted to do that yourself. So it's doing it for you and letting you know it's about a 12% risk of coronary vascular disease. So really what this is doing is helping mining using all this advanced technology to help me make better and smarter decisions. And the final thing I will say is that it's complementary and not competing. And that's a key thing here. We are not replacing the closed loop med administration, but this is bi-directional. So not only I can make a better decision if I put an order in through Wellsheet, it's going to the EMR as if I was doing it myself, and you're going to get that decision support and feedback. And this is why not only is this complementary for me as a clinician, but the EHR vendors are embracing it, because what we're doing is we are filling in the gap of what they are having trouble, the innovation, and we are using this technology and dynamically doing this to complement the EMR, but not replace what it does best. Next slide, please. So this is all well and good, but what is the proof in the pudding? So when we rolled this out across 7 Cerner hospitals on the same Cerner instance, and what it did is we measured before they were in Wellsheet, and then after in Wellsheet, and you can't game this, right? This is actual measurement from lights on. And we had almost a half, 44% reduction in time of actually needing to be in the EMR. And also just kind of complementing what was already, the stage was set on this. It was just a minor introduction, and it was so easy to use that they just spread by word of mouth. And not only did I have over 1,000 and up to 2,000 clinicians using this, including physicians. Our nurses just adopted it. They were able to take it and use it for handoff with actually very little training. So the result here is really helping us with our efficiency. Next slide, please. And the final proof in the pudding here is that it also made us happier. Again, I as a practicing and teaching physician, this has enabled me to finally give back to my colleagues. We've all spent time. It's not that what we're doing in the EMR is not important, right? And we do believe in getting rid of the small stuff. But even if you get rid of the small stuff, which we've been doing, you're still left with things that still need to be done. So by using this intelligent technology to help us make it easier to do the right thing, we were overwhelmingly more satisfied. And I love this on the right, the Net Promoter Score. Typically EMRs alone down in the bottom are more like paying for cable TV. But what we've been able to move the EHR into is more of a Amazon and Netflix. I think that's where we'd all like to be with technology, and just really shows what. So in closing here, I'm hoping I'm giving a proof of that this can work and we can do this. The interoperability that we've all spent years can be used just like other outside, we know in other disciplines outside of medicine, we're benefiting from it. We can now benefit from this with this partnership. And again, what I want to just encourage my colleagues is that let's continue to work together and do what we can to reduce burnout and use technology as a solution rather than a source of the problem.
Wow, thanks so much. No, that was perfect. And we'll have some time just to remind everybody at the end of this session, we're going to have Q&A with almost all the panelists from both sessions 1 and sessions 2. So keep putting your comments and questions in the chat. That was inspiring, Steve. Thank you. I think we all need a little inspiration these days. So next, I'm going to turn to Michael Ash, who's the Executive Vice President of the Chief Transformation Officer at Nebraska Medicine, who will share some of their innovations. Welcome, Michael.
Good afternoon, everyone. I appreciate the opportunity to speak with you today. As Stephen said, the prior speakers did an excellent job of setting up the problem. We can go to my first slide. And for background, I'm not going to spend a lot of time on this. We're a little bit behind schedule, and the prior speakers just did a wonderful job. So if we just progress, I'll go ahead and move us forward. And similar, this information will be available for download. The only focus is 2.8 times the odds of burnout if reporting poor marginal time for documentation. And that is part of the efforts and part of what I'll talk about today. We, like many organizations, started with some basic principles. One, we wanted to make sure that we were doing a good job as measured by external organizations. So achieved HIM7, inpatient, outpatient, Davies, most wired, the traditional bar if you're doing a good job with digitizing health. We also had some philosophical principles, a zero-sum game. What I mean by that, anytime we introduce new clicks, new workflow requirements, my team had to demonstrate a similar elimination of steps. So we couldn't cause more pain, more burden. Additionally, we did a number of steps, just as you would within your organization, of eliminating non-actioned alerts. We've eliminated in the millions, as well as clicks, obviously, into the millions similarly, and other low-hanging fruit, like introducing voice recognition in single tap. If you go to the next slide, and I won't get into the data, but the acknowledgement, all of those efforts, all of those external accomplishments, if you will, we still had significant issue. I was the Chief Medical Officer, VP of Strategy at Cerner before I came here, so where we use Epic. So I'm very familiar with both systems, both light-on, signal, and pulse. And we use those tools, as you should, to identify where is the pajama time, where are the people that are struggling most. We also set some internal goals and really use this terminology to partner with others around home for dinner. Through those exercises, because you can't be official unless you have a TLA or a 3-letter acronym. Unfortunately, we couldn't get it down to 3 letters, but we do call it our We Care initiative. And so it's well-being focused, engagement, compassion for you, your team, your patients, and awareness through improved communication, reduction of senseless tasks, and enjoyment. There was an excellent New England Journal of Medicine article years ago of getting rid of the stupid. It was from our friends in Hawaii. I've asked for a couple of site visits since I live in Omaha, but that just hasn't happened yet. But what has happened is a lot of progress of how can we be more human? How can we make these systems stink less, if you will? How can we have them work better for you? And some of this is just having the conversations that the physicians will relate to, is how can we get you home for dinner? How can we learn from each other? And where and when necessary, how can we do rescue training? So we actually use Signal. We monitor who we think are most efficient within the organization. We had one just 2 weeks ago, where in our monitoring of this data, we felt that there was potentially a physician that could be in crisis, given the amount of time they were spending 240 minutes. I'm going to pause for effect. 240 minutes after the end of their day working on documentation. This was a new person, new to our health system. And so called the chair, rallied the troops, really went in, intervened quite literally, helping them with documentation, voice recognition, et cetera. Additionally, if you go to my next slide, last slide, is we really have focused on innovation. When I was at Cerner, I'd worked with the Nuance team, Joe Petro, others, and we were the first site to go live with the ambient documentation assistance or intelligent clinical. You saw some of the video. This is Dr. Hartman. What we have actually found is the iPhone running this application works maybe even better than something mounted on the wall. It's less intrusive. It allows, at least for our room configurations, to work quite well. I think one of the takeaways that I would like to leave with you is one of our ear, nose, and throat docs is it really has decreased, in this example, his stress because he's not having to keep everything in his memory. What he was doing, and I did similar when I was seeing ambulatory patients, I would see 1 or 2 or maybe even sometimes 3 patients and then sit down and document. And that's very difficult to keep all of that straight. And so sometimes you'll document less out of that concern or trying to catch up on time. And so by having this tool working with you while you're interacting, it's an invisible technology, so you can be much, much more visible. The last thing you want to see when you're having a very serious conversation, if you're an athlete and it's ortho, or a singer and it's ENT, that the back of the physician's head while he or she is typing. So this is really allowed. To make this technology really work, this is my last comment, and would really leave you, having the physician get very good at giving a summary at the end. This isn't magical technology that can pick from all the different parts to create a perfect note. So if your docs get really good at giving a summary at the end, you were here today for, left knee pain. For that, I'm going to do X, Y, Z. We all know how the notes are constructed. The tool works incredibly well, and your patient satisfaction will go up as well, because they leave knowing exactly what is being addressed, how it will be addressed, and in a very empathetic, interactive visit. Future's bright. Hopefully it will continue to get better. And with that, I'll pass it on to the next panelist. Thank you.
Thanks so much, Michael. That was excellent. The last person we've got in this session is Jessica Dudley, who is the Chief Clinical Officer of Press Ganey, who will actually make an interesting connection between their data from employees, satisfaction, and tech. So I'm going to turn it over to you. Thanks, Jessica.
Helen, thanks so much for having me. And I'm thrilled to be here. And gosh, the first 6 speakers that we've had have really covered a tremendous amount, which I so appreciate. And I'm actually very optimistic, given what everybody's sharing, both the ideas of it and then the real implementation of it, that we're going to move forward faster. I do have some slides, just a few, and most of you probably think of Press Ganey like I did before I came to Press Ganey, as a patient experience company. But we actually collect a tremendous amount of data from the workforce, over like 1.4 million employees in healthcare and 120,000 physicians and APPs. So I want to share with you some of what we're seeing in that data. And I think you'll find it hopefully very relevant to what we're talking about here. One point I wanted to make about tech, and I think that we've covered it so well, and I'm really hopeful. Like I said, I still think, and I know a lot of people believe this too, that we are working really hard to take the tech right now and support the way we do things right now. But I think all of us would also agree that, in a few years, I suspect the way that we do things and the way we're using tech is going to evolve, because we will be integrating the tech in a much more active way. And I think about that, like even with my Apple Watch. I'm sure everybody on this phone is wearing some device, not everybody, but most of you may be wearing a device that's actually capturing data. And so making sure we figure out how we integrate that. And, some of the folks already talked about capturing that patient data and getting it integrated right away in the medical record, and then responding to that with artificial intelligence, so it doesn't all end up on the practice or specifically on the clinician that's often on the receiving end of all the data. So I'm very excited and hopeful that we will continue to evolve. And we are seeing lots of different folks around the country beginning to move into this space. So I'm going to share with you, next slide, this slide, which I don't think anybody's probably seen before because we haven't really shared it. But this is showing you what employees today are saying keeps them in their job, or the flip of that really kind of leads them to want to leave. And we heard a lot from the first speaker, and even from Lisa Rottenstein as well, about the data showing the challenges of burnout and retention of the workforce right now. And this is looking at the whole workforce, but I'll tell you that I've also cut this for just our clinicians, just our physicians, for our nurses, as well as all service personnel and management. There are slight differences, and I think that's an important thing to think about, is how we segment our data, because as others have said, it's not one size fits all. But the big things I want you to look at here are the stuff at the top. And a lot of people today have actually mentioned these, like why we're in medicine. And our first speaker shared a video with all these different clinicians reminding folks that it's about connecting with patients and figuring out how to do that well. That is still absolutely the most critical thing, is to figure out how to ensure that whether it's security personnel or our frontline clinicians, that they find their work meaningful, that they have the opportunity to connect with patients. And as you can see here, when people don't feel those things, they have a up to 6 times likelihood readiness to leave than when they do. And that's whether they're going to leave like today if they're offered another job or in 3 years from now. So it's so important that we address these tech challenges so that all of our clinicians, and not just our clinicians, all of our workforce has the time to connect, find meaning in the work that they're doing, and make sure they're part of this solve around quality care. I'm just going to highlight those green bars. We haven't spent a lot of time today at all talking about equity, but I think all of us are well aware of the challenges we face in this space, and this is really relevant to our employees. So folks who feel like their organization is committed to equity and inclusion are far more likely to remain than those who don't feel like their organizations are committed to that. So let's move to the next slide. I wanted to dive deeper into our data, and Lisa Rottenstein pulled some of this up when she was sharing the EHR burden and the differences that are felt by female clinicians versus other clinicians. This is an additional slice of data looking at how female, and this is specific for physicians. We've also run this for our female APPs, and we have some data differentials for nursing as well. But this gender difference is dramatic. And this is the perception that female physicians report about their experiences during work. They truly perceive that their unit is staffed at a they feel much less staffed than male physicians. They feel that they are not given sufficient time for patient care. They do not feel the respect that they're involved in decisions that affect their work, and they feel this overwhelming amount of job stress. And a bunch of folks talked about the Great Resignation, and we know that this has affected women more than men. So I just want to point this out because I think that all this data that we're sharing today around the EMR just emphasizes why women are feeling these differences. Next slide. So this is showing that, and we talk a lot about burnout. This is another way of thinking about burnout, which is about decompression, the ability to go home and recover, to get sleep, and actually disconnect from work. And we heard earlier about all of these great technologies that we hope will help keep work at work, so that when clinicians go home, especially those in the specialties with the intense level of documentation, they can actually stop working and be present at home. And what this slide is showing, so there's 2 different ways we think about burnout, or we actually talk about resilience. And the one I want you to focus on is the picture in the front. And this is when you go home and disconnect. The one in the back is finding meaning. Actually, all those things I showed you on that first slide, that when physicians find meaning in work and connect with patients, then their activation scores stay very high. And the picture in the back, the purple dots are female physicians, the green are male physicians, and it's for every age cohort. So female and male physicians actually have no problem activating and finding meaning in work, and that stays high across the age cohorts and relative to one another. But if you look at the front slide, the ability to decompress, to get sleep when you're at home and disconnect really varies dramatically between male and female physicians, with females being dramatically lower at every age range. So this isn't just about having young kids at home. This continues across the spectrum here for female physicians. And it's something I think is so important, and why these technologies and making them more usable and getting rid of the small stuff, somebody said it better, cleaner, is so important. Next slide. So I want to just touch on one last thing that we haven't really covered today, but it's so tech important, which is the use of telemedicine. And this slide shows what happened with the pandemic. That big green chunk at the bottom is, and you can't really tell, but before March of 2020, the number of telemedicine surveys that we were pulling in were in the hundreds. And then they quickly rose into the thousands and tens of thousands. And then the gray in the back are just in-person visits. So I think we all know that telemedicine really took off, and I'm very confident that it's here to stay. In fact, we see now about 10% of visits continuing in the telemedicine space. But from a technology perspective, whether it's the use of the EMR or the use of technology and interactive platforms, we still have a lot to work on to improve this, to make it anywhere near what the experience is like in the in-person setting. And what we're learning from this data is that our clinicians are actually doing a good job connecting with patients, just like we've all figured out how to communicate and connect in these platforms. So have many of our clinicians. But we are failing a bit in the use of our teams. And a lot of folks have talked about on this, the importance of integrating tech so it's used across the team and we leverage all members of the team, even in the inpatient setting. And we are just not, we haven't figured that out yet in telemedicine. So if you go to this next slide, and this is my last slide. So as we've looked over time, so the green are the virtual, these are the patient experiences with virtual care versus patient experiences with in-person care. And these come from the same, only of those locations where they're doing both virtual and in-person care. And as you can see, we've seen this tremendous closure of the gap with this, with communication and connection between patients and their physicians. And that's revealed by that summary number on the right, the summary where the two graphs are on top of each other. So patients are very likely to recommend their care providers, whether they're seeing them in person or virtually. But the big gap is that one in the center. And if 10% of visits are now happening virtually, and you want to keep your patients in your practice, it is so important that we figure out how to get the infrastructure, the logistics, the administrative and integrative components of our telemedicine to work better so that we can close that gap. And then the far left, which is a smaller gap, is just this ability of the staff working together with the care provider. And we know, patients' experience now, even in the ambulatory setting, is not an experience just with their physician or APP. It's an experience with the entire team. We have not yet figured out how to make that nearly as smooth as what it feels like in the in-person setting. That's my slides to cover, and look forward to the panel.
Thank you so much, Jessica. Those conversations really brought up so many interesting issues. Let's have